I've got yet another fascinating poster for you. Please introduce yourself.
Hello, I'm Professor Vaia Lambadiari. I'm an endocrinologist from Athens University Medical School in Greece, and I'm mostly dealing with diabetes and metabolic disorders.
You're very welcome. Tell me, what did your work find?
Well, it was about the 3 months treatment of high and very high cardiovascular risk patients with type 2 diabetes. That's meaning with multiple risk factors or with established coronary artery disease, which were enrolled to receive either standard of care like insulin on top of metformin, or a GLP-1 agonist like liraglutide, either an SGLT2 inhibitor like empagliflozin, or their combination. And we were actually enrolling 120 patients and studied them for 3 months. And what we wanted to see was the improvement in specific vascular and cardiac indices, irrespectively of glucose regulation.
So these are a particularly difficult group of patients.
Yes, it's from our cardiometabolic clinic within the diabetes center, and we follow them together with the cardiology department.
Okay, so 3 months later, what did you find?
What we found was that everybody improved in terms of HbA1c. However, when people were actually given the combination of liraglutide and empagliflozin, the improvements in cardiac contractility, or in microcirculatory and glycocalyx, or in arterial stiffness, pulse wave velocity, longitudinal stress, everything having to do with cardiac and vascular function was actually much higher when you combine these two medications compared to whether you give one or insulin as a standard of care treatment. And that was actually amazing because we saw that it's not the HbA1c that's the problem, because at the end of the 3 months, the HbA1c was actually the same in all groups. That is to say that there's something else going on that improves cardiac function apart from glycemia per se.
That's very interesting, isn't it? Because if you looked at the Verify study, again, we're looking at combination drugs and making, so rather than sequential add-ons, you're looking at doing combination drugs. And here is yet another example of that.
Well, yes, that's the clinical significance of the poster, that we have to think out of the box and think in terms of how to improve cardiac and vascular function apart from the metabolic derangement.
So what does this mean for the average clinician?
Well, it means that if a patient has had an MI or has multiple risk factors, or we think he's at a very high risk to develop a myocardial infarction or a stroke or something, then we should probably choose from these two categories, or if possible, combine them to have the maximum effect.
And presumably much better to do this for people who are at high risk, rather than wait until they've had some sort of event.
Yes, of course. Yes, that's the case. Having multiple risk factors is actually high risk.
So when this is an important piece of work, what's next on your research agenda?
Well, the 3 month period was actually struck us as a bit odd because it was a small period of time. Yes, and that was surprising. So we're now recruiting more people, and we plan to follow them for a year and 2 years to see if this is a sustainable result or if something changes within. And of course, if we drop out insulin, what happens? I mean, the HbA1c is better, but are people better with insulin? We don't know. So that's the next step for us.
Yeah, you have to ask yourself always with these type of trials is what really counts, what really matters. And actually, the HbA1c is obviously not important.
Exactly.
Very interesting. Thank you so much for coming to talk to us.
Thank you very much. Thank you.